In this video, we'll talk about hypo and hyperthyroid medications. In hyperthyroid disease, there is overproduction of thyroid hormones. Patient will be intolerant to heat, have high heart rate and blood pressure, and will experience unexplained weight loss. Causes can be Graves' disease, nodular thyroid disease, or subacute thyroiditis. For hypothyroid disease, there will be less thyroid hormone concentrations. Patient will be intolerant to cold, extremely fatigued, and will experience weight gain. Causes can be thyroid gland failure from chronic autoimmune thyroiditis called Hashimoto disease, or iodine deficiency, and it could be secondary hypothyroidism due to pituitary failure. We'll start talking about hyperthyroid medications, but now we need to understand thyroid hormone physiology. It's easy, so let's concentrate. The story begins with hypothalamus, which releases TRH, which is thyroid releasing hormone. This hormone goes to the pituitary gland and releases TSH, which is thyroid stimulating hormone. TSH goes to the thyroid gland and releases T3 and T4. Now, when we have high TSH, this means that we don't have enough T3 and T4. But if we have low TSH, this means we have high T3 and T4, and it's telling the thyroid gland that we don't need to make more. But how T3 and T4 are formed? They are formed inside thyroglobulin, which is a large glycoprotein synthesized within thyroid cell. But it needs iodine, so inorganic iodide will enter the thyroid follicular cell and gets oxidized by thyroid peroxidase. Then it will bound to triazine residues of thyroglobulin. 1 iodine plus 1 triazine will form monoiodotriazine. 2 iodide plus 1 triazine will form diiodotriazine. Now 2 DIT will form T4 and 1 MIT with 1 DIT will join to form T3. T3 is 5 times more active than T4, so T4 gets oxidized by this enzyme to form T3. Proteolysis within the thyroid cells releases the thyroid hormone into the bloodstream, and only the unbound or the free thyroid hormone can diffuse into the cells and elect biological effect. First treatment we have for hyperthyroid disease are thionamides like methimazole and probiothyrouracil or BTU. They block thyroid hormone synthesis by inhibiting peroxidase enzyme and by inhibiting the coupling of MIT and DIT to form T3. Also, BTU inhibits peripheral conversion of T4 to T3. Improvement in symptoms and laboratory results should occur within 4 to 8 weeks. Minor adverse reactions include arthralgia, fever, and benign transient leukopenia. Major adverse effects include agranulocytosis that comes with fever, gingivitis, oropharyngeal infection, and granulocyte count less than 250. Other major side effects include aplastic anemia, lupus-like syndrome, GI intolerance, and hepatotoxicity, especially with PTU. Second treatment option we have are the iodides, like potassium iodide. It acutely blocks thyroid hormone release by inhibiting iodine uptake into the gland, so it decreases size at the vascularity of the thyroid gland. Symptoms improvement occurs within 2 to 7 days, so it's often used as adjunctive therapy to prepare for a surgery, to acutely inhibit thyroid hormone release and quickly get to the euthyroid state in severely thyrotoxic patients with cardiac decompensation, or to inhibit thyroid hormone release after radioactive iodide therapy. Adverse effects include hypersensitivity reaction, salivary gland swelling, or the state of iodism, which is having symptoms of metallic taste, burning mouth or throat, sore throat and gums, symptoms of head cold, and sometimes stomach upset or diarrhea. Now we have radioactive iodide, like sodium iodide, which is an oral liquid that concentrates in the thyroid. Since the thyroid needs iodine, the thyroid takes the radioiodine into the thyroid cell, and the radiation destroys the overactive thyroid cells of their time. This causes the thyroid gland to shrink. Pregnancy is an absolute contraindication to this. Beta blockers are primary adjunctive therapy. If iodides are administered, they should be given 3 to 7 days after to prevent interference with the uptake of radioiodide in the thyroid gland. Patients with cardiac disease and elderly patients are often treated with thionamides prior because thyroid hormone levels increase after radioactive iodide treatment to a small amount. Adenergic blockers like beta blockers are used to alleviate symptoms such as palpitations, anxiety, tremor, and heat intolerance. Propranolol and nadolol partially block conversion of T4 to T3, but this contribution to overall effect is small. It is used as adjunctive therapy to all previous discussed treatments. The side effects include nausea, vomiting, insomnia, lightheadedness, bradycardia, and hematologic disturbances. Centrally acting sympatholytics like clonidine and calcium channel antagonists like diltiazem and vibramyl can be used as an alternative. Thyroid Thyroid storm is a complication of hyperthyroidism. To treat it, we need to suppress thyroid hormone formation and secretion, we need to give anti-adenergic therapy, and we need to administer corticosteroid. Also, we need to treat the associated complication or the coexisting factor that may have caused the storm. Now for hypothyroidism, we need to restore thyroid hormone concentration in tissue and provide symptomatic relief. It's easy. We have levothyroxine as the drug of choice. Administration of levothyroxine or thyroxine T4 results in a pool of thyroid hormones that is readily and consistently converted to T3. Levothyroxine is a drug of choice for pregnant women. For drug interaction, we have cholestyramine, calcium carbonate, sacralfate, ammonium hydroxide, ferrous sulfate, soybean formula, dietary fiber supplement, and espresso coffee may impair the GI absorption of levothyroxine. Drugs that increase the non-iodinative T4 clearance include rifampin, carbamazepine, and possibly phenytoin. Selenium deficiency and amiodarone drug may block conversion of T4 to T3. Another form is Lytharin, which is synthetic T3. It has higher incidence of cardiac adverse effect, higher cost, and difficulty in monitoring with lab tests. Lyotrix, which is a synthetic T4 to T3 in 4:1 ratio, is chemically stable, pure, and has predictable potency, but it is expensive and lacks therapeutic rationale. Excessive doses of thyroid hormone may lead to heart failure, angina, MI, and may lead to reduced bone density and increased risk of fracture. For myxedema coma, which is a life-threatening clinical condition that represents severe hypothyroidism, so patients will need immediate and aggressive therapy with IV bolus levothyroxine, or initial treatment with IV lytharin or a combination of both hormones because of the impaired conversion of T4 to T3. Also, we need to give glucocorticoids with IV hydrocortisone until coexisting adrenal suppression is ruled out. And that's the end of this video. Please don't forget to subscribe, share, and like.